Listen-only mode.
All right. Good afternoon, everyone. Welcome to the Community Health Training Institute Coalition Quality Improvement webinar. We're going to get started in a couple seconds here, but we're just letting people sign on, get situated. We hope that you can hear us well. If you can't, obviously you cannot hear what I'm saying right now, but we'll give folks a chance to kind of get on board, and then we'll get started in a couple seconds. All right, so again, welcome to the Coalition Quality Improvement webinar. Here today, here with Eric Hetty from Health Resources in Action to talk about a lot of exciting information around quality improvement. So before we get started, just some housekeeping. If you see there on your screen, if you wanted to join our email list or are not on it already, it's very easy to do that over text. If you wanted to text that number that you see on your screen, 22828, and you can put in your email address, and right away you're included into our email list. And as well, if you wanted to follow us through Twitter, our hashtag MA Coalitions, that's also another way to communicate with us. So for the next hour and a half, we're going to have some great information for you, but I want to go over some housekeeping first with you. All right, so before we jump in to the actual presentation, we have a quick poll that we would like you all to answer. And we will show this poll again at the end, and you don't need to answer it again at the end, but we want to make sure we capture everyone. But the poll that should have popped up on your screen now is your organization funded by the Massachusetts Department of Public Health for any of these programs or initiatives? So you can select all that apply or select just one if that applies for you. So I'll give you a couple of seconds to submit that information now, and then we'll go from there. I'll give you a few more seconds to fill out that poll, and then we'll close it. All right, give you a chance to keep clicking in. So again, we're asking what DPH program or initiative you're funded by. You can click more than one or just pick one if it applies to you. Give you a couple more seconds to fill that out. That's helpful for us to know in terms of who's in the audience. And then we'll do it again at the end to ensure that we get information from people that maybe haven't answered. Right. All right, so finish up with selecting, and we're just going to close that now. And again, if you didn't get a chance or you're just joining us, don't worry. We will do it again at the end, and this is helpful for us to know. So again, if you haven't been a part of our webinars before, just want to go over some housekeeping here. There's a questions box that you can type in your questions if you have any of them. Please feel free to do that throughout the presentation, but we'll also give you chances during the presentation to ask any questions you may have. And also, we will send out a link with the slides and the recording for you to have. And we also encourage you to use that hashtag, MA Coalitions, to tweet questions or comments at HRA Institute during or after the webinar. So feel free to communicate with us through several ways. And again, here's the question box. If you're not familiar, it should be on the right side of your screen there. And again, we're in the Coalition Quality Improvement webinar with Eric Hetty. My apologies. So we will get started with you all now.
Great, thank you, Daisy. Well, good afternoon, everybody. My name is Karen Ericetti, and I am a research scientist here at Health Resources in Action. I'm really glad to be with all of you today. I know it is around lunchtime, and I imagine many of you will be eating your lunch or having a cup of coffee while we get going here. So feel free to do that. And again, please utilize the chat box if you have any questions. Just a few things about Health Resources in Action. We are a nonprofit organization based in Boston. We have about 50 plus years now of experience promoting public health and biomedical research. Like many of you who are part of organizations and coalitions, our vision is a world where social conditions and equitable resources foster healthy people and healthy communities. So I'm hoping that our topic today engages you in that vision. Again, our mission is to help people live healthier lives and create healthy communities through prevention, health promotion, policy, and research. Our learning objectives for today are fivefold. I'm first going to discuss and define quality improvement in the context of multi-sector initiatives and partnerships. And part of that will include a description of the elements of the model for improvement version of QI, or quality improvement. I will say QI a lot during this call, so watch out for that. And I will also be talking about the method, the PDSA cycle, or Plan, Do, Study, Act, and this is the associated with the model for improvement, a framework for QI. We also identify core concepts in QI to organize a collaborative effort, including multi-sector partnerships, coalitions, and also organizational institutional efforts. If you're a hospital or healthcare system organizing an effort, this will apply to you as well. I'm also going to describe how to use QI data very briefly to assess improvement over time and describe strategies for sustaining coalitions engaged in long-term QI efforts to promote public health and well-being of communities. Well, it sounds like a lot, but we have some time. Now, this is a long webinar, so feel free to get up for breaks. And again, please keep those questions coming in. This is an overview, a roadmap for today. We are going to discuss quality improvement's definition first and why coalitions should use it. Quality improvement may not be something that you're familiar with, or you may be using and just not have a name to it. So QI can be part of what you're doing now. And I hope some of these tools are new to you as well, and you'll get something out of that. We will then move on to a discussion of the model for improvement and the Plan, Do, Study, Act method. We'll also talk about the steps that you can use to organize a coalition, whether you're an established coalition or you're a brand new coalition, or even thinking about organizing a coalition to improve community health. We'll talk about some of the tried and true strategies you can use to organize a QI approach. And the final two topics will be around using quality improvement data. We will only briefly talk about that. That is its own animal. It takes a long time to go through QI data, but I'll just briefly talk about how we use data to accelerate change in community health work. And then finally, we'll talk about sustaining quality improvement coalitions. I know many of you have chatted in your registration. That's important to you. We'll definitely talk through some examples. And finally, we'll have QA and next steps. So what is quality improvement, and why should coalitions use it? Quality improvement has a very long history, especially in Japan, where most of the work in quality improvement was done. Actually, it predates the 1950s slightly. Most of the work that we know and the methods and framework around quality improvement come from manufacturing in terms of improving processes, making things more efficient, making employees more productive, and producing higher quality widgets. QI has been adapted to a number of industries, including healthcare and public health, particularly with calls to action by the Institute of Medicine and others to improve quality Healthcare and public health have seen just a wildfire of QI initiatives that have sprung up over the last 30 years. And now quality is a very big topic and an important one in how we provide public health services and healthcare services to individuals in this country. And healthcare payment is, of course, now increasingly tied to quality through pay-for-performance mechanisms and value-based purchasing strategies. The ACA, the Affordable Care Act, has also expanded opportunities to improve healthcare equity, healthcare quality, and promote community health. And this includes strategies to enhance measurement and more transparency around measures of healthcare quality. The Agency for Healthcare Quality, as well as CMS, the Centers for Medicaid and Medicare Services, all have very transparent quality movements, but many public health agencies and departments across the country are also using quality improvement under the ACA, and is also part of their public health accreditation efforts to make measurement more transparent to the public. In addition, training and resources for QI have expanded over the last 2 decades. If you Google QI, or quality improvement, you'll find a plethora of tools that are free that you can use. In fact, there are so many of them that it's almost confusing to figure out what you should use because quality improvement has many names. There are many examples of quality improvement models all over the literature, and you probably have heard from some of these. Six Sigma, or the DMAIC version, they use the lean change management strategy, and this is used a lot by hospitals. People can obtain black belt status in Six Sigma. You can actually be a ninja in quality improvement if you want to. The model for improvement is, or the PDSA method, is also a framework. That's what we're going to be talking about today. It has been largely adapted for large-scale public health projects to address public health topics such as obesity, improving developmental screening for infants in hospitals, improving breastfeeding, helping people with sickle cell disease. There's lots of different topics that this has been adapted to. Total quality management and also the FADE models are also popular, but again, there's so many varieties, and they're really just meant to be a framework for you to think about quality and how you might accelerate improvement in whatever topic area you're working in, whether you're in health or any other kind of industry. So I thought I'd talk for a few moments about quality improvement. And again, just so you all are aware, I am a health scientist. So I do have a bias when it comes to thinking about quality improvement. But I want to acknowledge that not everybody on the call does work just in health. Many of us do work in human services, or we may work with law enforcement or work in schools. And I was also a school committee member for many years in a community in Massachusetts. So I am very well aware of what it's like to be someone with constituents to be accountable to, a member of coalitions, as well as a scientist who's working to promote health and community well-being. There's a definition I really like about quality improvement that was in a paper by Paul Batalden and his colleague Davidoff. QI is the combined and unceasing efforts of everyone, which in this context includes healthcare professionals, patients and their families, researchers, payers, planners, and educators, to make the changes that will lead to better patient outcomes, in this case health, better system performance, which is in this context care, and better professional development. So really at the center of this is the community, which is everyone. If we really focus on improving population health and outcomes, we use people, resources to do that, and we focus on improving the entire system that serves everybody. So it's really about putting people at the center of what we do. And as public health people and professionals, or people who are associated with community health and improving well-being of populations so they can be successful, that's really the core of what we do. And I think it's really important to say that out loud. The approach improving community health and QI is certainly based on that sort of ideology. Solving today's public health challenges is very complex. I don't think there's a public health problem out there that it doesn't have multiple areas where things need to actually happen. There are so many different issues that we need to solve when we're addressing these types of issues. For example, if you're trying to prevent bullying online to adults and children alike, it requires collective action to solve that problem. Most of our challenges that we work on, we work in sort of silos on technical solutions. If you're a nurse in a hospital and your ward is trying to improve processes, or you're trying to support a hand washing initiative, that's a very technical approach or solution to a problem, reducing infections. So you're really working at the organization level. You're identifying, testing, and spreading the innovations around hand washing, and you're doing that all across the organization that you work in this case, a hospital. But public health in the multi-sector context is really about adaptive solutions. We're looking at solutions that are multi-pronged. They occur at multiple levels, whether the individual, organizational, or community level. The socio-ecological model is actually a good way of thinking through the multi-sector partnership challenges that we all face and we're working on, and we require many partners to do that. So we're looking for multi-sector partnership engagement. Of course, this is one of the most difficult things to do, is to sustain a partnership to address public health in a broad context, and that is the topic that I will be focused on today in terms of describing QI.
Quick question, Karen. Mm-hmm. One's been posed. Someone was curious about the strategic prevention framework. Is that considered a QI model?
It is not. However, I believe that a lot of the same concepts can be used. Strategic planning and some of the precepts and frameworks are very useful in developing your QI approach. And if you're in a coalition, I strongly recommend that you explore strategic planning frameworks because they are so useful in organizing people, which is a key component of any quality improvement project.
Thank you.
Thank you. So I want to take a step back and just acknowledge for a moment there are many of you who are working on projects or developing coalition efforts or establishing a coalition. There are many pitfalls in putting together a multi-sector partnership, and I've just listed a couple of them here. I would be really surprised if none of you had addressed any of these, and these are the things that we face every day in terms of organizing work to achieve a community health aim. If you're working on obesity and trying to improve healthy living and wellness, or you're organizing an effort to improve financial literacy in the community, there are so many different things that we tackle, and these are some of the pitfalls that we come across. A lack of clear and shared vision. Some of us have the Toyota complex, where you have a plan that is too big to fail, and yet when it fails hard. The risk is high when you fail. Also, sometimes our coalitions are inconsistent in terms of who's leading the way. You can feel very isolated and alone if you're organizing a coalition and you are part of a key group of people who want to do something, but you just don't know how to get it all organized and together. There are also challenges in recruiting stakeholders, not just recruiting them, but finding the right people, and then retaining them and not losing them to burnout and attrition. Also, everybody has limited time, we have limited resources, and sometimes financial backing just isn't there for the thing that you want to tackle in the community. And finally, the last three are three of my favorites. Too much planning. A lot of times we're in a coalition and we're trying to build an effort with many different sectors, and we're constantly in planning mode, and it's really hard to get out of the gate and implement. So QI is a really great tool for getting out of the starting box, and we'll talk a little bit about that. Ineffective management and organization is something we all have to work on because management isn't perfect. It takes a lot of effort to coordinate coalitions, and you can use QI tools to actually improve how you are organized as a coalition. Also, policy changes. If you're in a community, you cannot discount that the environment you're working in might change, either through policy change, budgetary changes, cuts and things that happen at the state level, perhaps things that come down on the federal level that might affect what you're doing. So these are all things that are pitfalls of what people do in coalitions. And we're going to talk about how to use the quality improvement methods through the model for improvement to address some of these pitfalls. So I'm just going to briefly pause to see if there are any additional questions before we jump in on the science part. Are there any questions?
And if anybody, of course, along the way, will welcome questions as we go along. Hopefully this is as interesting to you as it is to me. So
Great.
We'll keep going.
We're going to plow through then. So let's tackle the model for improvement and the Plan, Do, Study, Act method. So the model for improvement is a framework and tool that is used in quality improvement to accelerate improvement. It was developed by the Associates in Process Improvement, and these folks do amazing work to promote the model for improvement and provide technical assistance on its use. It's been adapted to a multitude of industries. A lot of my examples today are going to be related to community health, but it does apply to many other spaces as well. So the model for improvement is really 3 questions in any order and answering those questions, and the method, the PDSA cycle. The cycle is used to determine whether a change is an improvement. And it's referred to loosely as PDSA, although you may have heard it referred to as PDCA or the Kaizen cycle or many other names. And you'll see in a moment the cycle may be something else to you, so we'll talk about that in a moment. Let's tackle the questions. So the first question is, what are we trying to accomplish? In this question, we're really trying to define what is our aim? What are we trying to do? And it's really answering these 3 sub-questions. For whom, how much, and by when? And I repeat them because they're so important. For whom, how much, and by when? I actually had to say this to myself when I first learned QI. I had to try to remember these questions because they are so essential in defining your vision. And if you're in a coalition or a collaborative effort where a vision is not clear, answer these 3 questions and try to develop consensus around this. You'll find that things will fall into place. So here's an example of an aim. By December 2018, the ABC County Coalition will reduce the number of injuries among people aged 18 to 30 due to violence by 30%. This clearly says for whom, how much, and by when. So that's the first part of the model for improvement. The second question is, how will we know that a change is an improvement? In this question, what we're really trying to understand is what measures are we going to collect so we know that improvement actually takes place. And this is through the collection of quantitative data. So an example would be the percentage of people with opioid addiction who find a bed in a treatment facility within 48 hours of ER admission. That's a tall order, but that's a very persuasive outcome measure that you might collect if you are doing a quality improvement initiative around improving systems of care for people who have opioid addiction. And finally, the third question. What changes can we make that will result in improvement? This is our science, our ideas, our theory of change, evidence-based strategies that we think will accelerate improvement toward the aim. So an example of that is perhaps if we open farmers markets in each town, we will promote access to healthy food. And this is not really a science thing, it's more of an idea that you might have, but if you're working on an Upper East City project, that might be something that you would consider. But it could also be some engineering changes at a hospital to improve surgical infection rates and reduce surgical infection rates. It could also be simply understanding or applying training or a toolkit that was developed to train staff to do something new in a provider context or at a school. And finally, the model for improvements method is the Plan, Do, Study, Act cycle. It's a method for bringing about improvement. And really it's four phases where you really approach change as something that is continual. These cycles are meant to be iterative, so that you start at a small space and you also apply the scientific method. You plan what you're going to do, you make a prediction, you actually do the experiment, you study the results, and you figure out what to do next. So I'm going to turn now to a short poll on Plan, Do, Study, Act cycles. And this is just really asking you to weigh in on what your experience is with Plan, Do, Study, Act cycles. And again, you may refer to PDSAs in some different language. Feel free to answer based on the language that you use. And we're just going to pause for about 30 seconds.
Giving people a chance to fill out that poll. We'll give you a couple more seconds. And again, like Karen said, it may go by different titles, and you may be doing some of this already, may not be calling it this, but definitely thinking about it in terms of this role. So We're going to close if you want to add your last piece there. So we'll close the poll now and see what people said.
All right, great. So over half of you have never done a PDSA. That's great, because we can start with a clean slate and figure out what to do. But I'm also really pleased to see there's diversity in those who have experience with PDSAs, from having planned them to conducting a few cycles, and some of you, and actually 1 in 5 have done several PDSA cycles. And I would just want to point out that there's always a diversity of experience when you're approaching a problem in your collaborative work. And people may have experience doing PDSAs and some may have a lot of experience. Quality improvement is really about learning. So we'll continue to talk about shared learning as something that we work on through QI, and we'll talk about through the rest of the slides I'm going to present. Great. So how do you plan a PDSA cycle? Well, first you make a plan, and in the context of a multi-sector partnership, you may have at the table many people who are involved in making a prediction. Your team will predict what might happen, and then you will figure out how you're going to execute this change. Who's doing it, where will it take place, and what will you actually do? And again, what data will you collect and how will you collect it? Because whenever you do a PDSA cycle, like any good scientific method, you have to collect data to know whether or not you've been successful. So your due is to carry out your plan and collect data, and then you study what happened and compare it to your prediction. What happened? Why did this happen, and what have you learned from it? Is there something that made it less successful, and what was that? Can we change something? Should we do another test, or should we scrap this entirely? Or if it was successful but just not completely successful, what would you do a little bit differently, tweak it, and do it again? And you can go bigger. If you start small, and again, PDSAs are about starting very, very small. You might test something out on 1 or 2 people or in 1 or 2 businesses. If you're going to work on promoting a public health awareness campaign at a school, and you want to test something like signs that you're going to put up about, please don't smoke here or something like that, and that didn't really work because that was a silly test, then you can just scrap it. But you can also try and make things very much larger than your original test. And the whole idea is to build on your cycles iteratively.
If I can ask quickly, in terms of this idea of PDSA, do you feel like the strategic prevention framework is a PDSA cycle or has elements of it?
I think there are elements of it. And again, that's a useful framework. You can use that to really test some great ideas. So if you're developing your strategy, your change concepts, that question number 2 in the model for improvement, those are the changes that you're going to try, your strategies. So you can plan them iteratively. You can also do hypothetical PDSAs and work through those. So there are some similarities. And again, the vocabulary of QI is so similar to so many other frameworks. So that's a really good point.
Yeah, so something you can use to enhance perhaps what you're already doing and not necessarily replace, but it sounds like they're line up.
For those of you who are on the phone who are involved in CHNAs or CHAs and are doing strategic implementation planning, this is a really great way of trying to think a little bit differently. You might try on this vocabulary for size, see if it sort of gets you out of the, if you're stuck, you can sort of think about PDSAs in that way. Thank you for that question. So this is a slide to show really the how visually you can roll up tests in the PDSA framework. Again, this is my artwork, so I apologize in advance for how crazy the slide looks. But really, I was trying to convey that PDSAs start very small and they get really, very large. And as you go, you start with an idea, and you work towards sustained improvement and holding that improvement as you learn from your data. And so this is really thinking about what happens when you try something out and you build on it. Here's an example PDSA in the context of a multi-sector partnership. Imagine if you had child care centers in your coalition, and there are 3 centers that are involved in reducing obesity in your county, and they want to see if they can get children to eat more fruits and vegetables. So those centers might plan to make apples and carrots available during snack times, something they don't normally do. Usually there's cookies and maybe something that someone's brought in. So not necessarily super healthy, but so we're going to try to change that. And they predict that half of the children during that snack time will eat one serving of fruit or vegetables every day. And they're going to test this out on Thursday in one of the 3 child care centers. So again, starting small, picking something and making a prediction, and then by when? We're going to do this on Thursday. In QI, we always say, what can you do by next week? In 1 week, what can you accomplish? And that is the scale of defining your PDSA. In this case, ABC Child Care Center made those foods available at snack time on Thursday afternoon. But what they found was that only a third of the children chose to eat fruit or vegetables during the test. Most of the children ate cookies or crackers. So they got together with the other child care centers and said, all right, we're going to repeat this because we learned from it. This time we're going to give them disproportionately more apples, which I totally misspelled, apologies for that, and carrots. And they're going to be more of those in crackers and cookies. And at the same time, Superior Child Care Center will conduct the same test on the same afternoon. So they're both scaling upward and trying something different based on their learning. And that is an example of how you go to scale with PDSAs. So here's where it gets tricky. Now, if you're going to be doing lots of PDSAs and you're in a big coalition with tons of partners and stakeholders, you can't just work on one PDSA at a time. You have to work in parallel. And you might be working on different areas. So as you're thinking about how your coalition is organized or thinking about your strategic planning and what you have been working on, you may have come up with your strategy and you want to separate into work groups and work on a couple of different strategies. So here's tobacco cessation. Many communities are working on improving and promoting tobacco cessation strategies as part of a larger statewide plan. A group might be working on quit lines, and they might be conducting a bunch of PDSAs to help improve people using the quit line, which we know is a very effective strategy for getting people information and getting started in cessation activity. Another group might be working on policy and increasing the excise tax on tobacco products. Another group might be working on access to tobacco cessation tools and medications. School-based prevention might be another group. And again, they're all working iteratively on ideas or hunches they have or even evidence-based practice. And I finally just wanted to mention that there are other groups you can create when you're doing multi-sector partnerships. I've just noted here, maybe you have an entire group where you have convenience store business owners all working together on marketing and how they market to young people. That might be something you would do. But again, it's bringing partners who don't ordinarily work on these types of things and having them come up with ideas and strategies and testing them out where you are. That's what the QI process is all about. Here's another collaboration example, and I wanted to talk a little bit about mental health because several of you have indicated that you're working on mental illness as well as substance abuse and severe mental illness in particular. So I made up this example of ABC Integrated Behavioral Health Care Initiative. It's a coalition that's trying to improve primary care access for people with severe mental illness, people who have schizophrenia or bipolar disorder or major depressive disorder. The coalition includes 2 outpatient mental health centers that are in the community, and they're just outstretched. They have so much going on, but it's really hard to get people with severe mental illness to come in for their appointments, and when they do, they feel like there's a missed opportunity. Well, they're part of this coalition, and in part of the coalition has community health centers and transportation partners. So for the PDSA, one of the 2 mental health centers might give out transportation vouchers to 5 patients with severe mental illness. The idea is that they're good for transportation to any community health center through the coalition's taxi and public transit partners. So they predict that half the patients will use the voucher to seek primary care at a partner community health center. But when they do the test, only 1 patient used the voucher. So their team gets together, and the transit people, the community health center, and the 2 outpatient mental health centers get together and say, we're going to do this again, but we're going to do it with 5 patients, and we're going to make them appointments before they come in. So if they leave our clinic, they're going to have a voucher and they're going to have an appointment. So that's an example of a multi-sector PDSA. And again, it is collaborative, it involves many different stakeholders, and it really has, this example has everything. So when you think about putting together a PDSA, you have to think about scale and the breadth of what you're trying to do. So I'm going to pause now to see if there are any questions. I'm very good at pausing. I'm very comfortable with silence.
Awesome. So we'll give folks a chance to type in any questions that you may have. We've had some good ones so far in terms of people thinking about current frameworks that they're using and how this PDSA model fits into it. And again, you know, this is additional tools for your toolbox, not necessarily asking you to change what you currently do, but to think differently or maybe add elements of this QI that may, you know, help you in your work. So, you know, if there's anyone who has any particular questions or want to raise any challenges or challenges they foresee with trying to implement this, we'd love to get those down.
So we have a couple of questions. If my funder wants me to use a different method, should I defer to that? So that's such a great question because we are beholden to many different sponsors when we do work in community health or really any area. And sometimes your funder has a very specific framework to work. And again, you can only really listen to your funder and try the things out that they ask you to do. However, there's nothing to stop you from trying to do your own internal quality improvement work or to adapt some of the philosophies of QI to your work, particularly if you find that it's useful or helpful. For funders who want to use a different strategy, for example, they might want to do a demonstration and do research. And research is not the same thing as quality improvement because you really are testing out the scientific method, but at the whole level, not at a small level. QI emphasizes testing things out in a low-risk environment with very few patients or very few people or very few agencies. And your N is N equals 5. In research, you're really asking a broad question, and you're using research methods and statistics in order to understand if an improvement has actually occurred. And that's when we use randomized control trials and things like that. So there are some, you probably should defer to your funder, but you can also make a compelling case if it's not working. Use QI to your advantage. Test out what the funder wants you to do in QI and see if that works. Just go to some other questions. Some of the common challenges that there are in QI doing PDSAs. I'm just going to sort of infer that that's what your question was. So there are many challenges in QI, one of which is to understand how to do things in a small way. It's very hard to boil down a very large topic like obesity prevention and test things out and boil it down to pieces. We're going to talk about driver diagrams in the next section, which will help us think about some of the ways you can make things small. The other thing is building capacity. QI is relatively new, and in different sectors, QI is not broadly understood. If you are working outside of healthcare in particular, this may be completely foreign to you, and you may have some capacity challenges and have to teach these tools to other people. So you become the teacher after applying QI. And again, QI is all about shared learning. Failure is such a humongous part of what QI is about. It's almost more important to fail than succeed in the beginning so that you can learn. And that is counterintuitive to some folks. So that might be something that you might need to consider. All right, I'm just going to look at the other questions. I think we're good for now. Let's move on to our next section. And really in this section of the webinar, we're going to be focused on organizing a coalition using quality improvement. Again, going back to those challenges that we have and trying to organize when we have a really important thing we'd like to do in the community. We're just not sure how we're going to organize or put our coalition together. Or perhaps your coalition isn't as successful as you'd like it to be. And QI can be a great way to approach that. Again, I want to encourage everyone who's on this webinar. It is a long webinar. Please get up and stretch if you feel like it. Have an apple or carrots as we did in our example. And come back to us. These slides will be here for you after the presentation. All right. So There are many steps to organizing a multi-sector or a partnership or coalition with quality improvement, and they're really well-defined steps. Most of this originates from the Institute for Healthcare Improvement's Breakthrough Series model, which I'm not going to be talking about here, but we will send some resources out about how larger collaboratives are organized. And they all start with picking a topic. And sometimes this is the hardest thing to do. And again, going back to strategic planning for a moment, if you are using the strategic prevention framework, you may find that's useful in picking a topic. We're going to talk a little bit about how to do that. The second step is to convene a team or multiple teams. I'm going to talk about what it means to organize a team within the QI space. So thirdly, you're going to define your data-driven aim of your multi-sector partnership. Going back to question number 1 in the model for improvement, what are we trying to accomplish? Knowing that that's measurable. Number 4, select changes your coalition will make. What's your science? What's your theory? What are you actually going to test out? What do you think is the magic, pixie dust of all this stuff? It wouldn't be a presentation by Karen Nuriketi if I don't mention something related to Disney. Apologies. Number 5, determine a measurement strategy. You really do need to think about how you're going to know you've been successful. And again, going back to that question number 3 in the model for improvement, these can be addressed in any order up to this point. Number 6, test your changes and study the results, and study them iteratively from small to large. And then finally, refine your tests and implement successful changes to scale. There's an 8th step that we're going to talk about, which is sustainability, holding your gains, and we'll talk a little bit about after the fact. So let's start with picking a topic. If you're in an organization or in a coalition that already has done, for example, community health needs assessment, or you have some good baseline data, look at that data collaboratively with your partners. What direction is it telling you to go? Are you getting a direction from a funder that says, this is important to me, this is important to my organization or my foundation or the government? And what are they trying to accomplish? What do they like to look at? So it's good to look at your data and to either narrow your topic or broaden it based on your data. So again, you can look at a multitude of public health data sources, and I'm really just going to say that data is a very broad topic. We will probably plan something about that in the future. But data is data. It can be quantitative or qualitative. Figure out what in that data speaks to you about where to go. You can use this conversation, picking a topic, to organize your coalition. Invite people to come and talk through what your topic is going to be, what's important to them, and have them select priorities. What is feasible for us, for example, to achieve? What can we reasonably do? If we're under pressure because something has happened in the community, like for example, for the anti-bullying movement, there was an absolutely terrible, terrible suicides that occurred in Massachusetts, and of course they're occurring in the country. And that was a call to action for people to come together in communities and talk about anti-bullying. Who's going to be at the table for that? How are you going to do that? How are you going to adapt what you're doing to state law that has just been revised related to bullying in the last 5 years? So that's an example of how you can pull people together because there's a call to action, but there might not be. It could be a topic that no one seems to care about, like opioid addiction. That's a tough topic, and maybe you're interested in it, but there's not a lot of social support to address it. So again, getting people together and figuring out what can we reasonably accomplish together. You can pick multiple topics if your coalition is motivated to tackle multi-pronged problems. Again, healthy living is a very good example, but also public safety. Financial literacy is a new topic that I see communities tackling. There's many things you can work on. Again, it all goes back to picking something that you feel as a collaborative that you can address together. There are many different tools to go through prioritization. In HRAA, Health Resources in Action, has many different tools that we've used in the past to help coalitions select priorities as part of strategic planning and implementation. So again, that's a different topic, but there are resources out there. Second, we're going to convene a team to do quality improvement work. Now, a quality improvement team is a bit different than most teams that you would envision doing public health work in the community. Typically we get together and we split into groups and we work on things together, but QI suggests there's a way to work and there are people that need to be at the table in order to make that happen. And these are really 5 areas that I think are really important. First, there needs to be a sponsor, and this is not necessarily the funder, but this is typically the leader, somebody who's engaged and will coordinate and lead the QI effort and will make sure that the precepts of quality improvement are in play, conducting PDSAs, going to scale, and looking at data. That person is typically called the coordinator, but they are also the project manager on occasion. Then you have people who are content experts, people who know they're going to do the implementation. They're the people out in the field doing the work. Again, ABC Child Center that I mentioned before, that's a content type of person or organization. And then you have project managers, people who are out there and actually coordinate the work in the field, who make things go. Fourth, you have technical experts. You might find that you need to find faculty, and faculty I use loosely because faculty could be people with doctoral degrees or people who have no degrees whatsoever. These are people who are experts in their field. It could be a recovering alcoholic who wants to share knowledge about their experience. And then finally, consumers. You should always include in your quality improvement team someone who is the target population, who represents what you're trying to do. If you're trying to prevent falls among seniors in your community or across the county, your team should include seniors who either are at risk for or who have had a fall, or their family members. Those voices are incredibly important because they will give you good ideas about what to do to prevent these things from happening or to move forward the cause that you've selected. Teams in QI are diverse and they're task-oriented. They boil things down into pieces. And coalitions often are made up of several QI teams. Consider using a workgroup structure. There are many different ways to work, but workgroups are amazing because they say work in the title. When we split up into subcommittees for some reason, and I can say as a school committee member, that doesn't suggest you're going to do any work. Work groups are great because it means you have something to do. And in the QI context, you give people something to do and a deadline. It's very important to give teams, hey, remember what we're trying to do. And Model for Improvement question 1 is by when. So if you're trying to do something by December 2018, that's your charge to each work group. Each work group should have a charge of what they're trying to accomplish so that they know that what they're doing is part of a larger group effort to improve community health or whatever aim you have. And again, I can't say this enough, do not forget to include patients and families or your target population in your QI teams. All right. So why are we doing this? This is number 3. Defining your aim, the question of the Model for Improvement, number 1, in your multi-sector partnership. It's really important to have a good aim statement. And it's something that you can revise if things do get better, which is why I love this cartoon. When you're in a QI project, you want to set a clear vision and have a focused mission with measurable goals. And that is, again, a part of making a good aim statement. This is something that's owned by all partners, approved by all partners, and it's informed by community and contextual issues. And it's very important in a coalition to be aware and beware of broad agendas. You've got partners who might come to the table for the first couple of meetings who might say, I want this. This is the most important thing to me. But it might not actually be the ingredient that will move your work forward. You've got to focus your partnership by establishing goals and infrastructure to support those goals. And that includes figuring out which stakeholders are going to be seated at the table who will buy into and own that aim. And again, going back to prioritization, do engage in a prioritization exercise based on your community health data so that you can focus your efforts. We're going to talk about the tools of QI for a moment and the aim statement. An aim statement is a written and measurable description of your coalition or organization's desired improvement. It is a manifesto, a charter, a charge, a call to action. This is an example of a multi-sector level aim statement. You can actually bring these down a level and put them at the work group or organization level as well. But given the context of our work today, I wanted to give you an example of something that addresses a community problem at the highest level. So by April 2017, by when? The ABC Substance Abuse Coalition will reduce the number of deaths due to opioid overdoses by half across 25 communities we serve. That's the manifesto. It says by when, who we're going to work with, people who have opioid overdoses or at risk for it, and then you're going to reduce the number of deaths by half. That's a pretty big statement. And of course, I made this up not being somebody who works in this area, so it might not be possible, but let's go big or go home. So as part of this AIM statement, these are your goals. We will advocate inclusion of opioid prevention in town budgets to cover training of first responders. We're going to train law enforcement officers in every police department on the identification of overdose and the use of naloxone, which I always mispronounce. Apologies. We're going to train paramedics and ER providers in overdose protocols. These are well-established protocols. Massachusetts Department of Public Health, for example, has a fantastic resource page that talks about how to train people, what they should know how to do. And then finally, we will conduct a community-wide opioid addiction awareness campaign and referral program. This is a pretty bold statement, but it's large enough to encompass many different partners, and there are a lot of people who need to be involved in achieving this. And it's by April of 2017, which is not that far away. Most QI projects are done within 2 years. 12 to 18 months is the typical range, but they can be much larger depending on your project. Here's another example for the folks who are on the call who are doing dental work, and there were several of you who registered. Over a 3-year period, the ABC Oral Health Coalition will reduce school absenteeism among school-aged children caused by tooth pain by 50%. We will increase screening for tooth pain by 50% among school-aged children. We will increase access to on-site school dental services by 25%. We might use some strategies like mobile dental services. We're going to increase the number of dental providers in our community who accept Medicaid by 30%. And we're going to conduct a parent awareness campaign to recognize the signs of tooth pain. This is an example of a bold QI statement. This says exactly what you want to do, for whom you're doing it, and by when. It's very important to have a lot of data in here too. What are you actually going to achieve? And this is where you can use your coalition to figure out what's feasible and what they want to be part of. This is something that everyone signs off on and gets into. And it also has to be measurable, which we'll talk about in a moment. So I'm going to pause now for some questions. I've said a lot, and I want to see if there's anything that people would like to ask now before we complete the steps.
You know, and please type those in as we go along, but those are some really concrete AIM statements, which were really helpful to think about, you know, how people are doing it currently in their coalition. So, you know, if there's any questions or comments you have regarding this AIMS, or even just getting this work done, challenges that you have confronted or foresee, we'd love to hear that from you all.
Sure. And we will keep going. Do not seem to be any questions at this time, but if I see one pop up on the screen, I will certainly address it.
Awesome.
So the next step in the process is to select your changes. What are you actually going to do? QI changes can be anything from evidence-based practice in peer-reviewed journals to an idea or a hunch you have by going to the movie theater and seeing something you thought might be a good idea. And that actually does happen. I've been in projects where people have said, I saw this in a movie and it might work. So QI doesn't necessarily have to be scientific. It just has to be rational. So that's really important.
It's a quick question there on whether AIM statements and vision statements are the same.
That's a great question. So they are similar. An AIM statement, again, includes for whom, by when, and how much. A vision statement generally talks about what your vision for the world is. If everything was the way you wanted it to be, what would that look like? It doesn't have to be quantitative, and it doesn't have to be specific. An AIM statement allows you the flexibility to be specific about what you like to do. Great question. All right, back to selecting changes that are from Hollywood or peer-reviewed literature, which is really where you should find your ideas. You can adopt the work group structure with aims for each of your work group and have that work group brainstorm what they think might work. And this is a great technique because you'll be planning and trying to figure out what might work contextually in your community. It may be that you have great ideas and there's been things that you've seen in other states that have been modeled, and you want to adapt that model for what you're actually confronting in your own backyard. But it might not be contextually appropriate. So you might have to figure out, well, how could we adapt that idea? And your work group can be a great way to figure out, okay, what are those strategies? Again, it's strategic planning, but in a QI frame, which means they have to be very specific and they have to be small ideas at the beginning. Next, you need to engage experts within and outside of your partnership. Your partners are experts. They know their stuff. And even if they have a prickly exterior or a really nice smile on their face, you still need to engage them in the same way. It's a good opportunity for you to ask them to be partners with you and provide their expertise. People like being asked about what they know about, so that's great. Finally, if you have a big enough topic that's a really difficult topic to work on, and I'm going to go back to opioid addiction, that's a very difficult problem. Or anything related to addiction is incredibly difficult. Mental health issues are also another area. You may not have all the science or the strategies you need. So how do you get that information? What are your ideas? One strategy is to hold an expert meeting to develop the strategies based on any data you've collected or any data out there in the field. And you bring and convene faculty, whether they happen to have degrees or not, and have them discuss what they think those ideas are. If you're trying to promote breastfeeding in a community, you might want to bring in people who are representative of that community and ask them what would work if this were you, or what worked for you. You might want to do a patient survey or a community survey or do focus groups. There's great ways to get information about strategy. You can also develop and apply an existing change package. And this is where jargon gets kind of messy. In QI, we refer to something called the change package. It is quite literally a list of things you can do in a package. It's a set of evidence-based strategies that are organized by the driver of that change. And we'll talk about drivers in a moment. You can Google change package for any topic, and you might find a whole list of things you can try, because organizations across the country and the world have developed change packages to address problems. So that's somewhere you can go. And now we're a part of my favorite part of the presentation where we talk about driver diagrams. So I'm sure many of you on the call have looked at logic models. Logic models are excellent ways of describing how a program works, but they don't help you figure out what system you're working in. And quality improvement is all about figuring out what's in the system that you're trying to improve. And a driver diagram is really working from left to right, goes from an outcome to the things that make that outcome happen to the secondary things that make that outcome happen. So you use arrows to describe relationships between those drivers, things that drive change toward your outcome, all trying to achieve an aim. So here's an example. My aim is to be a healthy Karen in 1 year, which is so not going to happen. But it's my aim, and that's what I really want to do. I want to be healthy. My outcome measure that I've selected is reduced weight. So I'm going to know whether I'm healthy by reducing my weight. My primary drivers are what everyone tries to change every day of their lives, their calorie intake and their calories out. So what drives calories in and calories out? My secondary drivers include reducing my total intake of food, substituting low-fat foods for high-fat ones, and reducing my alcohol consumption. Again, this is a very individualized, hypothetical example. I don't actually drink, so it's not really relevant. Calories out. I monitor my steps with a pedometer. I wear a Fitbit to work every day. And that's how I monitor and make sure that I am getting active. I have physical activity. So I also want to work out and take the stairs. So this is my system for creating a healthy Karen. But if you're working in a multi-sector partnership, you get a lot more complicated. It's important to develop a multi-sector partnership aim. So it might be a healthier weight in the community, and your outcome measure might be percentage of adults who are obese or children. And these are some drivers. I'm not going to go through all of the drivers, but you can see how this is set up, that it shows the relationships of things that you would do in a multi-sector partnership, promoting healthy eating and physical activity in a community. And some of the strategies you would use are secondary drivers. Examples are building community gardens or farmers markets, senior center walking programs, and improving safety and lighting on sidewalks. So you can see the level change. I did talk a little bit about measurement, but measurement should be tied to the changes you're making. So you need to know if you're achieving your aim and if you're making progress toward that aim. These are straight up outcome and process measures. So that example of weight loss is an outcome measure. Process measure might be, are we building enough gardens? How many farmers markets do we have? Balancing and structural measures are qualitative measures. What's the context for our success or failure? You might want to measure something like do a survey of your patients or people in your community. Keep your measurement strategy simple. Keep it in these three categories and focus on the outcome and process measures. Here's an example strategy. Again, I won't go too much into this. There are percentage, this is an example from bullying. Percentage of children who report being bullied might be your main outcome measure. Some process measures might be people who've been trained, the percentage of teachers who implements procedures according to policy, the percentage of students who take anti-bullying training, and so on. And you might do a survey of families about student perceptions of bullying in school. Number 6, test your changes and study the results. And this is where your PDSAs come into play. Develop your sub-teams and your coalition and test ideas and strategies that are represented in your driver diagram. Your driver diagram is your science, what you think works to move your overall outcome and your aim forward. Do regular meetings and report to your larger coalition. It's incredibly important to get people to come to your meetings. If they're not coming to your meetings, they're not engaged in your quality improvement work. So you might want to take on a small sub-project about how to get people to come to your meetings, because that is a driver of your success. And of course, emphasize shared learning and not judgment. Failure and why strategies fail are opportunities for improvement. And that's what QI is all about. So don't lose heart if something isn't working. That just means that you're moving forward. Take on strategies that you can implement and be targeted about those. Don't take on the world, because QI is about taking on a small island with a flag on it before you move forward, taking on the entire community, the entire state, the entire nation, and then some. You will fix it with your village. Your village has to be on board. And finally, refine your tests and implement successful changes to scale. Results of PDSA should be reviewed by the entire coalition and refined. They might be refined in your work group, but you can review them and talk about things that may be difficult. Your PDSAs just aren't working, you might need groupthink. So grab people who aren't in your work group and ask them for an outside perspective. The most effective, promising strategies should be selected for scaling upward and then carefully built upon, adding more and more people and organizations. Not all strategies can be tested in a PDSA, for example, policy changes. Atul Gawande, who's an excellent writer and physician, has written extensively on the idea that you can use checklists to figure out if you've done certain things. And in the policy arena, you can develop checklists to monitor whether or not you've advocated for and achieved a policy. The outcome is the policy itself, so that's your outcome. You might want to track how far you get by different steps that you would use to actually pursue policy change. So that's something that is structural and cannot really be tested in the PDSA. However, you can track it. With scale comes larger coordination needs. Ensure your coalition has a strongly coordinated infrastructure with a communication strategy. Many coordinators of coalitions signed up for this webinar today, and I was pleased to see that there are many people interested in doing this. There's an entire system of strategy that you can use to coordinate quality improvement efforts, and it all comes down to having regular meetings and collaborative sessions where you share learning and review data, combined with regular communication. There are many tools about this which we will send out following the webinar. I'm going to pause briefly for questions. We only have a few more topics to cover, and then we're going to take broad questions and finish up with some next steps.
So giving you all a chance to digest a bit. If you have any immediate questions, feel free to type those in. We will keep it moving. We will have some great other topics to explore as well. So it looks like we have a question.
Is it most helpful to have all three types of measurements? It's essential to have an outcome measure. It's helpful to have process measures. It's not necessary to have balancing measures. That's how it's a mantra that I have. But if you don't have a good outcome measure that really measures what you're trying to do, then you won't know if you're successful. So that's question number three in the model. How will you know you've been successful? Make sure you really get that right. And test out your measure if you're not sure, or collect multiple outcome measures. Process measures tell you a story, particularly when you're trying to pull the lever on something that's hard to change. You're trying to get obesity to change in a community. That isn't going to happen within a year. It might take 5 years for you to move the needle on that. So process measures are a great way to tell your story about how you've done your work, what you've achieved. Checklists are also great at that too. And when you're beholden to funders who want to see that you've moved the needle, process measures can be a great way to give them interim data. So keep in mind that process measures are your friend. Balancing measures are great for figuring out unanticipated problems. So it's great to have sort of some structural checks on what you're doing as well, but it's not necessary to do. I'm going to move on given the time, but if you have questions, again, stretch, have some coffee, and chat those in. I'm just going to talk briefly about quality improvement data. QI is all about shared learning and learning from this in particular. Data, data, data. Measurement is the foundation of building improvement. When you're building a house, you invest the most money in your foundation, and QI is no different than that. QI data represents the scope of what you're doing right now, and it doesn't necessarily represent the whole system. Going back to that child care example, you might want to collect data on all the kids in one center, and then your denominator will shift to all kids across all 3 centers, and then all kids in all the centers in one county. So your denominator might shift. This is a hard thing to kind of wrap your head around, because as your changes go, you're measuring different types of populations or different entities. So that's really tough sometimes when your intervals, as represented on a line chart, don't actually represent the same population. It's not research data. It's also very helpful to do, because then you don't have the time intensity to collect a lot of data you don't need. Start with your baseline data. You can get 2 or 3 points of data. Set a baseline before you try anything, so you know what your baseline is. It should be part of your coalition's routine to collect data, even on a small scale, from your PDSAs. And remember, qualitative data matters. Listening to your target population, providers, and families is incredibly important. You must utilize your coalition to collect stories about QI efforts. Utilize new tools in social media, take video, use Twitter, use Facebook. There are so many different ways you can capture the voices of people affected by your work in coalitions. Here are some example measures. I'm just going to mention a few of them. Percentage of children who report being cyberbullied, that's an outcome measure. The number of banks with financial literacy classes might be a process measure, but it also could be an outcome measure. And my favorite, the number of new partner members at a coalition meeting. If you want to address internal issues with QI, make some measures about attendance and people coming to meetings or people speaking at meetings. Measure the effectiveness of your coalition right along with what you're trying to change in the community. Here's a brief example of a run chart. This is an example of how we use data, and it's quite simply a line graph that shows the percent of patients here in this example who wait more than 6 months for a psychiatry appointment. This is something I encountered when doing a community health assessment for one of the Chenal districts in Massachusetts. It's a major issue, and you'll notice here that you track the data, the percentage of patients, but you also look at a goal and you look at your median. So another example, we annotate in QI. We kind of put stuff on our charts to say what happened here. You see a plateau, you put down, well, something happened here. Funding delayed for training in 2 towns suggests that we got stuck here, but then we got unstuck somewhere in July. So it just tells you a different kind of story. I include this slide for your purposes after the training. This is just the rules of QI data and how to interpret run charts. Print this out and keep it for yourself. but we may have to do another training on this topic. It is a huge thing to talk about, but this is the rules that you would use to know if you've been improving. And finally, sustaining your coalition efforts. Most coalitions that I know that are on the phone or who have done work in community health have to plan for sustainability at the start. They have to build a governance structure that's aligned with improvement processes, that has an aim, that has a work group structure, that has accountable people heading those work groups, heading the entire coalition, that regularly gets together and looks at data. And it all starts with choosing an accountable team to lead that coalition who believe and buy into quality improvement. And you must align those resources that you have with improvement work. If you have resources that aren't aligned with testing out new ideas that you happen to find when you're at a movie theater, or you are, trying a new idea out that your funder doesn't really buy into, that's not going to be aligned with improvement. So knowing the context and parameters is really important. You must also implement systems to support shared learning. This includes communication systems, good use of email, good use of meetings. Don't waste people's time when you have meetings. Have an agenda. Make sure you document things. There are a lot of things you have to have in order to manage shared learning. You might want to set up a wiki. You might want a Facebook group that's closed where people can contribute what they are learning as they go. There's sky's the limit on developing systems to improve shared learning. And again, failure is part of that. Failure is almost as important as succeeding. Review your data continually to identify opportunities for action. The best coalitions who use QI well take immediate action when improvement starts to slip. And that's why having those run charts or any other data, a checklist, reporting out matters. And when you see something that isn't working, the knee-jerk of the entire coalition should be what's happening there and what can we do collectively to fix that, because we only want to go up and not down. But that could also be a learning opportunity. Maybe something isn't working in what you're trying to do and you have to go back and start small again. Develop your coalition capacity for QI. Teach the people that need to know how to do QI, the QI tools, and have them own that. It's very powerful to teach people QI because it feels like that oftentimes people say to me, I feel like I now know the language I was speaking because I was doing this the whole time. I just didn't know what to call it. And now I feel empowered to go out. I'm going to test this idea I have out. I'm going to work with people. I'm going to track my data. And you can see it light up in their face when things change and they can see something move for the first time in the work they've been trying to do. It is incredibly powerful to share those tools with others, especially when they see data. It's wonderful. It's a wonderful thing. And a couple of closing slides. QI is dynamic. Improvement is about change. And I don't know about you, but change is something hard for me to embrace all the time because it's just part of life. It's hard to change when you're doing work, and people in the community who have issues that you're trying to address, they're also trying to change and you're working to support their change. QI will only work for your coalition if it embraces the concepts of learning and collaboration. And that again goes back to who's on your team. Do not be afraid to change your team if you can, or limit people who aren't engaged in this at all. Give them something entirely different to do. Because if you're going to be doing this, you need to learn together and collaborate together. Do not be afraid to change your aims based on your data. If you're working in a project, don't keep reinventing the wheel. There's a lot of good cartoons for reinventing the wheel I didn't put in here. But you know when something isn't working, change what you're doing. It applies to individuals and it applies to public health as well. Tackle new issues as you get more experience and diversify your coalition partners as you take on new challenges. I've been living in Boston most of my life, and every day I remember I would drive into the city and see this sign about the Big Dig. I often wonder what would have happened to the Big Dig had we used a quality improvement framework where everyone on that team was on board to accelerate change. Can you imagine how much money we would have saved? And Teradyne would not have had to have this horribly ugly sign in front of their building. There are so many problems that we work on and tackle in public health, They're all worthy problems, and we work very hard to improve people's lives every day. QI is one tool in our toolbox. We have many tools we can use: strategic planning, research, QI, implementation science, and evaluation. There are many things that we can do, but one of the big things is innovation. We all have to be innovative and think outside of the box when we're trying to improve problems that can't easily be addressed. So we want to work really hard not to be in this situation like the Big Dig. And that is my final message for you. I'm just going to leave you this slide about successful QI coalitions examples. I'd love you all to Google the Health Improvement Partnership of Santa Cruz County. That's an example of a QI initiative, a collaboration that's been going on for many, many years. In fact, they were recently cited in IHI's newsletter about the triple aim. If you want to see what a really good, well-operating coalition using QI is, that's a great example. So feel free to visit their website. I'm going to leave you with the key takeaways. I'm not going to read them, but I know that everybody on this call has come here wanting to learn something new. I hope that I've been able to do that today. I'd be happy to take any of your questions as well. And feel free to contact me. We'll be wrapping up some slides. I'm going to turn things back over to Daisy.
Awesome. Thank you, Karen.
You're welcome.
And again, I'm learning a lot new here as well. So, this QI framework and also PDSA could be something that you can add to your current work and not necessarily change everything that you're doing, but hopefully you're walking away with new tools and a new framework that can reinvigorate and inspire you all in your work there. So I'll give you all a chance to, if you have any questions, to type those in. But of course, here's Karen's contact info. She's more than happy to take any questions over email or phone calls. And of course, this is a much larger conversation. And some of the topics that she brought up, we actually do have on the calendar for coming up later on in the year. And also, we welcome any suggestions or ideas of additional topics or, technical assistance needs that perhaps we could just take in and then figure out how we can better help you. So as we're waiting for your questions, we do want to circle back with this poll that we started out with. And again, we welcome everybody and all to attend these webinars, but are curious in terms of who in particular may be funded by DPH funding source. So if it doesn't apply to you, that is perfectly fine, but we just want to get a gauge of who's in our audience. So if you want to take a few seconds to fill out that poll, if you didn't at the beginning of the webinar, if you did, there's no need to fill it out again, but just giving you some framework. But please tell your colleagues and your friends our webinars and trainings are open to all. We just hope that this help moves your work forward and keeps the conversation going on improvement. So I'll give you a few more seconds and then we'll close. And again, you don't have to fill this out again if you did already at the beginning. So get those answers in, and we'll be closing the poll now. So thank you so much. And just to give us an idea of who's in the audience, and of course, I'm sure there's more also from the registration and the feedback form that we hope we'll receive from you. After this webinar is over, you'll get a link for it. But just to give you a heads up of some trainings and webinars that are coming up. In fact, sustainability and resources has been talked about. That's a training, in-person training that's coming up, as well as building your coalition capacity and infrastructure. How awesome it is to think about quality improvement or talk about it before we get into the nitty-gritty. I find that to be helpful in a way to think about how do we know when we're successful, and then really getting the tools and the conversations going to get there. We also have a webinar, Improving Community Health Through Local Policy Change, coming up in December. And these are just a few. There are more on the website, and you're welcome to go on the website and also to join our email list. There goes that plug again for that number to add yourself to our email list super quick. Of course, you can also go to our website, Twitter us, go to LinkedIn, or email us. There's many ways to get in touch with us. And last but not least, also getting in touch with Karen and her expertise and knowledge about QI and PDSA specifically, and many other measurement tools. So If there's any questions, of course, we can take them even after the webinar, and you will get a link to this recording and the additional resources, and you will also get a survey, and we would ask you to please fill that out. We'd love to hear what you thought about this. So on that note, we are just going to wrap up and want to thank Karen for such a great and informative webinar, and thank you all for attending, and also to the Department of Public Health for making these webinars available free to everyone who can participate. So have a great afternoon all, and hopefully we'll see you on the next one. Thank you.